Welcome everyone once again. This is Dr. Imaze Marian Davis, podiatrist here at North Shore Medical Center, here at my Marian Footcare podcast. Thank you for joining me. So today we have another interesting case for you. Today we're going to talk about the risks of losing a toe even when you're not diabetic. All right. So today I'm going to present to you a patient who is a non-diabetic, only has high blood pressure. Okay, there's a lot of people out there with just blood pressure alone. But this patient actually had a prior injury, which was an Achilles tendon rupture. So an Achilles tendon rupture from years ago, and patient had chronically lived with this condition, which completely altered the way this patient walks. So the patient presented to my office with the problem and also having what we call hammertoes deformities, right? So this patient initially, when they presented with the hammertoes deformities and the Achilles tendon rupture, this injury had already gone on for such a long time, and the patient had done countless amount of physical therapy and actually was able to restore some strength to the calf area and was still able to push off the ground. And the patient opted not to have any surgical repair of that tendon because that tendon was already long scarred and at least had some functionality to it. What actually happened was that the patient ended up developing pressure callus lesions. Callus lesions are when our skin gets so hard, it almost feels like stone at the tip of our toes, because this patient again had hammertoes deformity. We talked about hammertoes last time, but this deformity with callus lesions starting to build at the tip of this toe of this patient who's 80 years old, who does not have diabetes, just blood pressure, has beautiful blood flow. Okay, that was not the issue. But this patient's callus lesions was just getting worse. And by the time he came to me, he was already presenting signs of infection to the toe. We went ahead and processed this patient like we usually do, which was to get an x-ray of the patient, look at the quality of the bone underneath the x-ray, and also went ahead to get an MRI to check to see what is going on underneath the soft tissue to see if the bone was affected. Unfortunately for this particular patient, the patient ulceration was severe enough that the infection from the soft tissue had already gone down into the tip of that toe bone. So the patient opted to have surgery to remove the toe, which was the second toe of the left foot. So if you look at the clinical presentation of the patient, you can see the ulceration of that left second toe, and you can also see how hammered the toes are. If you look at the x-ray of the patient, you can see that the patient has a pretty high arch foot. And for patients who have a high arch foot, what we call a pes cavus foot type, cavus, almost like a cave, right? These patients will end up developing pressure sores on the tip of their toes from the hammering of their toes, as well as, they get a lot of pressure on their heels as well. So, but this particular patient, all the problems that we're starting to see was showing on the tip of the toes, especially if this patient is also dragging their foot due to the old chronic Achilles tendon rupture and injury that they've been dealing with. So we took the patient to the hospital. We went ahead and did the surgery to remove the infected bone from the tip of the toe. And the patient ended up with a shorter toe on the second toe of the left foot. Okay, so you can imagine this patient is devastated that they've already had to lose partial toe of their second toe. This patient is not diabetic, people. So that means a lot of you out there who think that you're not diabetic, that you can have a toe amputation. This is a real reality here. So this patient obviously also being in a little bit in denial of what's going on. I started paying attention and making sure this patient follows up with us on a monthly basis. And we started noticing that this patient's problem was not over at all. This patient ended up having new callus lesions, callus hard skin, and ulceration on the big toe of that same left foot, as well as on the third toe of the left foot. So we immediately spoke to the patient, and I said to this patient that, listen, the fight to save your foot is not over. These lesions can lead to further ulceration. He seems to be very prone to infection due to his lifestyle. He likes to walk. We're in Florida. I would like to walk, whether it's with sandals on or just barefoot. We don't want the same situation to occur again, where this patient is going to lose, whether it's a toe or partial toe. And so we opted to use our minimum invasive surgery technique to go ahead and alleviate those toes and prevent further ulceration of those digits. So the patient opted for an in-office surgery. Again, with minimum invasive surgery, we can effectively take care of patients' foot and toe deformity by conducting minimum invasive incisions to straighten out those toes and to go ahead and balance the tendons and ligaments of this patient's foot. So we went ahead, and if you can look at the x-ray of this patient, that shows on the side, this patient already has the partial toe amputation of the second toe. The big toe is also hammered. We can also get hammering of our big toe. And that hammering, you can see the callus, the lesion on the big toe. And then you can see the ulceration and callus on the third toe. So we went ahead to do a minimum invasive procedure where we made an incision, a small incision on the head of what we call the proximal phalanx, which is just the bone of the big toe. We made an incision through it, and we went ahead and elevated. We did what I call a dorsiflexory wedge incision, osteotomy of the proximal phalanx to elevate the big toe and prevent further ulceration. So that toe went from this angle to this angle, which is where we want the toe to sit, so that you can effectively walk on the bottom of the foot versus on the tip of the toe. We also went ahead and did a couple of other tendon balancing procedures, which is the extensor hallucis longus tendon, which is the tendon on the top of the toe that allows us to extend the toe. You can see from the prior view that this tendon was under a lot of tension. So we went ahead and relaxed that tendon with a Z-plasty incision, and that tendon immediately reacted well, and the toe was able to sit in a much better position. And we also did some lengthening of the flexor tendon. So again, that tug of war we talked about in the previous podcast of the tendons that causes the hammertoe, we went ahead and balanced the tendons to allow the toe to sit in a more, flat position. The other toes, the third, fourth, and fifth toes, if you look at the picture again, you can see how the knuckles of those toes are just up in the air, and this patient's literally walking on the tip of the toes. So again, we went through using minimum invasive surgery to make small incisions that you can barely see, to make bone cuts, like molding the toes to be in a much flatter position. And we did also the tendon balancing of those toes as well. We went ahead and strapped the toes. You can see the white stero strips, which is the sticky strips that we use to hold the toes in the position that we want it to be. And we were able to effectively correct the toe deformity, allow the bones to heal and mold in that new position. The position is very natural position. It's not a very rigid position because we don't have any metal K-wire in there. We don't have any hardware in there. We're avoiding use of hardware, especially with the possibility of infections from those skin lesions, and making cuts that are very far away from the areas of the calluses, and allows the bone to just heal naturally by just taping and holding it in the right place. The patient will go ahead and be in a surgical cam boot, which is those space boots that you've probably seen people walk around with. And they're able to walk from day one of the surgery. And what you find out is that over time, as this patient heal, that areas of calluses will just disappear. They will just go away because the patient is no longer walking on the tip of their toes. So let's just think about what just happened. We had a patient who came to the clinic a little bit too late for us to save the second toe that had gone grossly infected due to the hammer toe deformity from the patient literally traumatically walking on that toe, right? Causing ulceration and then that infection getting into the tip of the bone of that toe. We were able to do the surgery to do the amputation and allow the rest of the second toe to be salvageable, which is good because we wanted the big toe to have like a little baby toe to rest on so that we don't have such a huge deformity of the foot. And the patient responded very well to my partial toe amputation, right? And then we went ahead and prevented the patient from ever losing the remaining toes of that same left foot, okay? By doing minimum invasive procedures, which were just done in an in-office setting, all right? While the patient received their antibiotics, wore the proper post-op surgical shoe wear, which is the cam walker boot, and then followed up weekly for x-rays and skin check. And the patient did fabulous. The patient was able to live their life. You can see images about a year later to see how this patient has done so well. The bottom of the foot looks like beautiful skin. There is no signs of pressure, no signs of callus, and the patient is able to live a normal life. So guys, I really hope that you enjoyed learning something new about a non-diabetic and how toe deformities, just like a hammer toe that we overlook every day, especially in our elderly patients, can really become a monster, and it can lead them to a toe amputation if we do not provide the proper treatment for the patient. So I hope you learned something. I see you next time in our next podcast. Take care.